Okay, so good morning, ladies and gentlemen. So I'm Nakazono, Hosei University from Japan. So our topic today was supposed to be examining family members' mental health as a possible index of caring burden, but because of the difficulty in analysis, we changed topic. Then the new title is Examining Effect of 2005 Reform on Certification Process and Self-Assessed Health. I'm sorry. So let's So this is content. So firstly, I briefly explain about the preceding study and its limitation, followed by overview of long-term care insurance in Japan. After that, I will explain about the data and its representativeness. Then I would like to talk about our analysis, aim and method, result, and conclusion. So in Japan, there are several studies regarding the burden of caregivers. Also, a few studies which examined about the certification. However, almost no study deal with the policy change effect on certification process and the burden of caregiver. Why? So I will show the limitation of the previous studies. So they usually use a very small sample size. It's about less than 100. Also, so their coverage rate is very low. They usually focus on one district or city, so very small area. And then also their sample is not random. They select certain person. As a result, their results are usually not consistent with each other. So moreover, so their survey is only one time, so not repeated, so they cannot assess the policy effect. So moreover, also they are only focused on main caregiver, do not consider other family members. So therefore, our objective is to overcome the limitation of the previous study and to focus on topics which are not assessed so far. So to do so, we first employ the large data, which calls the comprehensive survey of living conditions. Here after we call life survey, it's very large sample and randomized data. Then we also special attention to the changing in care need certification level and procedure, which are changed dramatically in 2005. Then we would like to find out how much policy change affects the probability of obtaining certification. Also, we want to analyze the policy change impact on self-assessed health. To do so, to analyze this impact, we also cover the both main caregiver and other family members. Because we believe that if the family have those who need care, which not only affect on the main caregiver, also affect on the other family members. So before moving our analysis, I briefly explain about the structure of long-term care insurance in Japan. So insurers is the municipal government. So municipal government, they are responsible for planning and providing services. Who is insured? So once we reach 40 years old, we have to join the long-term care insurance. It is mandatory. And the insured, there are two categories. Category 1 is for age 65 and over. Category 2 is age 40 and 64. What's the difference? The difference is eligibility requirement. For category 1, who gets certification, they just meet the care need condition. On the other hand, the category 2, they must have the care need condition with predetermined disease, which must be age-related, which are specified by only 60 specified disease determined by government. Through certification process, they can get need certification, then start obtain services. Then So as for the care needs certification process, there are two steps. First judgment made by computer based on the doctor's opinion and the door-to-door investigation and interview by qualified staff. Then the second judgment was made by the committee. Then as a result, they can get the care needs certification. So through this process, government wants to guarantee the objectivity and the fairness. So as for reform, so first, the long-term care has a 3-year business cycle. And every 3 years, municipal government has to review their business plan. And since 2000, implementation of the long-term care insurance, there are several reforms have been done. So among these reforms, we would like to focus on this one, 2000 revision. So there are 5 main points for reform in 2005. Then, so our focus is here to change category of care needs certification. Also, they try to improve care needs certification process for those who have dementia. So our research focus from this point. As for care need level category, before reform, only they have 6 categories. After that, they created a new category, support 1 and support 2. So all the support became the support 1. The old care level 1 divided into support 2 and care level 1. So it means that some people who used to obtain care level 1 cannot obtain the same level, and usually they categorize into lower level. So as shown in this chart, so care level, those who obtain the care level 1 is decreased. On the other hand, the support 1 and support 2 here is increased. Then what's the difference between them? It's like that. So the amount and kind of services are determined according to the category level. So between the category, the support and care level, what they obtain services are very different. So among them, the huge differences exist. So to summarize the effect of 2005 reform, the kind of service are restricted and the amount of service also restricted. And premium also increased, out-of-pocket payment of facility service increased. As a result, we expect the increase in financial, physical, mental burden of family. So we would like to analyze the effect of policy change carefully by using the representative data. So here I would like to show one more slide. This our help means those who require help, and H search, this means those who successfully obtain certification. The difference between them, from 2000 to 2004, the gap is actually decreasing. However, after the 2004 to 2007 or 2010, the gap between need help and get certification is expanding. So we will analyze the reason of this trend later. So what kind of data we use? This is an overview of data. So survey name, I already mentioned. It's a comprehensive survey of living conditions. This is conducted by Ministry of Health, Labor and Welfare since 1986. So data collection is certified random sampling. The sample size is 0.29 million households and its members, so it covers 0.76 million members. So it's huge large sample survey. Then, so before we proceeding our analysis, we need to check the representatives of data. We use the monthly and annual report as the reference. That report is based on the frame data, so their data is more precisely reflects the precisely show the situation of the care need people. So first, we compare the rate of certification. There are different. So the blue line is reference based on the monthly and the annual report of long-term care insurance. The red line is the data we use, life survey. So there are differences between the rate of certification. However, the trends are quite similar. So as life survey use questionnaire, it is very likely that the response rate of those elderly with difficulty are low, so it results in the difference, this gap. Then we look more closely about the rate of certification by age group, care certification category, and year. So except for age 40 to 64, we can see the same trends actually over year. This is 2001, this is 2004, 7, and 10. Some differences exist, but the trend is very similar. We think the reason of difference in age 40 to 64 is that the total number of obtaining certification are actually very small, so it is difficult to capture variation by life survey. Also here is so care level increase, the difference actually it's become wider. We expect the life survey use a questionnaire, so those who have the very severe care level, they cannot answer the question, also they likely to stay at the facility. So overall, we believe life survey shows very similar trend, so it is reasonable to say that life survey almost represents the nation. So now move on to the analysis. First of all, the aim and the method. We like to assess how policy change affects on the probability of obtaining certification. So method, the data we use comprehensive survey of living and conditions. Here we have four, the 2001, 2004, 2007, 2010. The analysis is made, the pooling cross-section using logic regression for probability of obtaining certification. We use the stator and the dependent variable is obtain certification. One is obtain certification and zero is otherwise. Okay. As for independent variable, we control the characteristic of those who require care. Also, we control the socioeconomic factors such as prefecture, income, and expenditure, and so on. This is a result. So with regard to independent status, independent status 1, 2, 3, 4, the blue, red, green, and the orange. So 1 is light condition, and 4 is a very severe one. So then this is year 2001, 4, 7, and 2010. From 2001 to 2004, all level, actually the probability of the obtaining certification increased. After the reform in 2005, the rate of the certification, the acquisition is decreasing for the independent status 1 and 2. So they change to the on the other hand, so status the 3 and 4 they are gradually increasing. So we can see here the policy changes, and then it affects the probability of the certification acquisition. So this one we focus on independent status. So next slide we focus on the dementia. So we look at by age group. So actually, the age less than 65, the number of people who get the certification is small, so there is a deviation is very wide. So please look at here, more than age 65. So the blue line is year 1, the red line is year 4, and then year 7 and year 10, 2010. So year 1 and 4, the rate of the certification acquisition is low. However, after the reform, the acquisition certification is increasing for dementia. So usually those who have dementia keep the good physical condition, that is, a good independent status. So there existed the criticism that the rate of certification obtained by dementia are low, despite they need huge support and help. So our result reveals that the policy change done in 2005, which put more attention to dementia condition, are implemented successfully. So we also look at the similar effect of the cerebrovascular diseases. So again, this graph, so the gap between, as I mentioned, the gap between the obtaining certification, requiring help and obtaining certification became wider. It would be highly likely that the burden on family with those who need care increase. So we try to measure the burden of care by self-assessed health. So using self-assessed health to measure the subjective burden seems to be promising. Today, most social surveys have the self-assessed health questions. So recent tightening of the long-term care insurance authorization seems to have increased the subjective burden. However, we face an indigeneity problem. For example, the primary caregiver are very serious. So actually, we are still working on this self-assessed health. So we will show the tentative result here. So firstly, we need to estimate the best function of self-assessed health. One of the problems in the self-assessed health function involving informal care is endogeneity. Problem principal caregiver is assignment. Also, a different family structure most likely means different distribution of care responsibility. So it is better to estimate an SH function separated for different family type. So we use the 3 different family types. So one type is husband and wife only. The second one is husband, wife, and children. We call it second generation family. The third one is husband, wife, children with husband's parents or the wife's parents. We call it third generation household. So in order to minimize heterogeneity in a sample, we will limit our sample to only one person with care needs or less. So it is example of 2-generation family, 2007 to 2010. First, we expected the care burden increase, but the result is actually opposite. From 2004 to 2007, the burden of self-assessed health actually improved. On the other hand, 2007 to 2010, it's become worse. And this is a 2-generation family result. So as for 3-generation, we have similar result. So here we think that so we focus on long-term care insurance. At the same time, the healthcare insurance system also made a reform. It is done in 2006, so we have some kind of the mixed effect here. So we need to isolate pure baseline for comparing to long-term care insurance reform. So 3 is the tentative result. So interpretation of the long-term care insurance certification. So our results show that now of 3 years tested, the marginal effect of long-term care insurance caused statistically significant difference in families providing informal care with or without long-term care insurance benefits. So this probably means that the subjective health of family with long-term care insurance certification changed in similar fashion with those of family managing without long-term care insurance benefit. This is a conclusion. So we have modeled the authorization process of long-term care insurance. So long-term care insurance had been given preferential treatment of those with dementia. The other medical reasons have been losing importance in the long-term care insurance authorization process. So limitation of the ADL, the activity of daily living, have been dominant in the reasons for long-term care insurance authorization. So those who have lighter impairment in ADL are now having a hard time in getting the benefit authorization. Also, finally, the tightened procedure resulted in increase in caregivers' burden of care in the 2-generation and 3rd-generation families, but not in 1-generation family. Okay. That's all. So thank you for your attention to my presentation.